Welcome to InnerSight, Health Optimization with Rudy and Sean.
Right. Hi, Sean. Here we are. We're rolling into our fourth year of podcasts. So this is podcast number 37.
You actually counted.
Yeah, we have to actually, for our people, we have to tell them they can go and look back where we started. So it's actually becoming a discussion today where we couldn't really find any more something or anybody more really knowledgeable than us two out there. So we are going to have a discussion, especially after you've just done the international certificate on peptides.
Yeah, Rudy, I didn't really want to do this podcast because it's like putting your head in a beehive. But we get so many questions around peptides that we'll need to talk about the subject. We'll need to touch on some sensitive points and see where this goes.
Yeah, as I said to you, I mean, we talk about longevity, and I'll take the flack for bringing us here to talk about peptides. But we had to do the research and go and learn, because we talk to our people, build the pyramid, get yourself to a place where you're actually making a difference at the top of your life, not the bottom. So, and this specific talk today is on peptides, which is right at the top. So once you've sorted out all your little things, it's right at the top of what you can do. So, and we have so many people on peptides. Where they get them, we don't know, but at every dinner conversation we go out with, we hear people on peptides.
Yeah, I suppose our practice a bit skewed towards recreational athletes. We see a lot of mountain bikers, a lot of people doing the Ironman, a lot of triathletes. So in our practice, most of the people, they still work, but those are the guys that started coming to us about 3-4 years ago already, and pitch up with some peptides. And like, we didn't know much about peptides at that point in time. And we realized that we need to start looking into peptides and just educate ourselves around peptides and what's available to start off with, and what does the research say about it. So our journey on the peptides is already like 3-4 years going on, but we've reached a point now where you see it on every post. Social media is flooded with information about peptides, and everyone just, almost mention it as supplements. And I'm like, whoa, people, stop. You can't say it's a supplement. So I think we need this conversation today.
Yeah, exactly. So maybe let's roll back to actually say what peptides are and what they are not. So as with us, peptides are not new. So they've been with us since humans were there. So now we just need to frame them as where they fit in the picture. So maybe in your mind, how do you think about them?
Well, I think if we refer to peptides, all of us think as like medicine. It's like not, as I said, definitely not a supplement, but a pharmaceutical doing something to frame it as peptides. Yes, peptides is a natural occurring thing in the human body. But when we talk about peptides, we talk about something that you usually inject into the body to do something specific. So
there are hundreds and thousands of peptides. So how I think about them, they are built up of a few amino acids, but they're not a protein. So all proteins are peptides, but not all peptides are other way around. So all proteins are peptides, but not all peptides are proteins. So you need to have an amino acid, stick them together in a long line. If they're under 50 long, it's a peptide. Longer than 50, the thing twists into a 3D form, and that's protein. That's my oversimplification of how I see it.
So there's a gray area regarding definition when a peptide becomes a protein. And we all say around about 50, some definitions say around about 100, definitely under 100, but most of the time we talk about under 50 as peptides, but then you look at something like insulin, which has got 51 amino acids, but that's still a peptide. So there's some gray areas there. But I think basically amino acids is like letters, A, B, C, D, whatever. Peptides are the words, and proteins are the sentences, just to put it in perspective.
Yeah, and that makes sense then for us to say, but they've always been built. So, I mean, if we think about the peptide that people know, but they didn't know it was a peptide, and everyone's been using it for the whole of last century already, is insulin. I mean,
Yeah.
that's the easiest one, is to say, but insulin is a peptide, and quite a lot of our hormones are also peptides, like oxytocin and all those naturally occurring peptides. So there are loads of them as well. So I don't think people, when they talk about peptides these days, think about those guys as peptides. So it's
Well,
more,
I don't even think when we talk about peptides, I refer to the weight loss peptides. I mean, when you see it on social media, it's all about the others. But we need to discuss where it came from, like insulin, and then go down the road until we get to that position where we can speak about those that we don't really have data on.
yeah. And I think this sharp end of medicine now, this conversation is probably going to move quite quickly, almost like AI is moving quite quickly, because I mean the first peptides were built in 1960, and the chap got a Nobel Prize in 1984. So this is not new. I mean, this is when I was in primary school. That's when he got a Nobel Prize for making peptides already. So, and I think that process is probably why we're sitting here, is we have to educate people that we are making synthetic peptides that people are injecting into their bodies, and we probably just need to talk about how that process works and how it doesn't work.
So I think that's a very important point that you bring up. So peptides, are they natural? Absolutely. Naturally occurring peptides in your body. The peptides that you inject, are they natural? Sometimes not. Many of them are engineered to either last longer, like a GLP-1s, or other ways that they manipulate it in a pharmacology type of way to get added benefit from the peptides. So it's not the natural peptide anymore when you inject it into your body. Okay. And the other question we get, but if it's natural, it must be safe. Now just take insulin as an example. You inject someone with too much insulin, you're going to drop their glucose and you're going to kill them. So no, it's not necessarily safe. It depends. It depends on the dosage. It depends on the type of peptide that you use.
So what we're actually saying, it's a signaling molecule. It goes somewhere in the body and tells the body to do something. So that's why people are using peptides, is to tell the body to do something. And I think we should maybe use the GLP-1 as an example of how it works. Because, I mean, there is a lock, and the GLP-1 is the key that goes into that lock and then tells that signal what to do. So GLP-1, the name says exactly what it does. So it's a glucagon. Glucose-like peptide number 1. So let me get it correctly in here. So so the GLP-1 unlocks the key, and then it tells the body to do a lot of things. But in this whole research, we actually realized that it's got a lot of other consequences. But actually, we started using it as a type 2 diabetes drug to lower insulin. It was found to for the people that used it that they lost weight, and that's how it became a weight loss drug in the end. So
yeah, so the natural occurring peptide, the GLP-1 that you secrete, every time you eat or drink something, you secrete this natural occurring peptide called GLP-1. Now, the thing with that is the half-life is around about 1 to 2 minutes. So it gives your body a signal, well, you've eaten, stop eating, you're supposed to be full type of thing. But it only lasts like, as I said, half-life 1 to 2 minutes. So what pharma did is they changed that GLP-1 so that you can inject it and then it lasts for 1 week. Completely a game changer, because you're going to get the same signals than the natural peptide, but it lasts for 1 week, more or less.
Yeah,
And that's a game changer.
And that's quite interesting, because I mean, people now think about semaglutide or Ozempic or tirzepatide, Mounjaro. People hear the new name retatrutide, which is now in phase 3 trials. They hear these drugs and they think it's always been like that. But I mean, you are 100% correct. That it was found years and years and years ago, the GLP-1s. It was the manipulation of that molecule that got us Byetta, that needed to be injected twice a day. Then came Saxenda, that needed to be injected once a day, and then only came semaglutide. So it is evolving, and now they've added the GIP to tirzepatide, and now with retatrutide they've also done the glucagon antagonist. So
to be honest, the GLP-1s, that started the whole hype. I mean, obesity is such a disease worldwide. And, you know, there's a reason why it's on every social media post. It's a reason why it's such a successful drug, because it works. And I think from even us as doctors, we always say, like, just where's your willpower? Just stop eating. And I think people need to understand that we've got different genetic makeups. And if you've got like a snippet on your genes, like the FTO gene, which has an influence on satiety centers, you don't have that willpower because genetically you've got that snippet. The same is with the leptin receptor as well. So you become leptin resistant if you've got a genetic change on that genes. Now the GLP-1s came along and that fixed that problem. So even if you've got that genetic problem and your so-called willpower is not that good, you can have that willpower now that someone else might have because they don't have that genetic changes with the new drug. And we see the results, and the results are amazing. So it started off with semaglutide when we started using the GLP-1s. That's the first one that we actually used. And the studies, that first trial showed about roughly 15% weight loss on semaglutide.
And the nice thing is, as you say, the peptide, GLP-1, and now GLP-1 plus GIP is amazing at what it does, and it's got some good downstream effects. We now know it's good for the heart, it's good for insulin sensitivity, it's good for the brain. So it's actually much better than we thought in the beginning.
But that's also a good point, because that's exactly what peptides does. It interacts with the receptor and then it causes downstream effects. So we knew this is a very specific receptor and that's what we expect to happen. And then we saw all these other things happening. That's all downstream effects that we didn't know. Fortunately, it's positive downstream effects.
Yeah, but still they are not without risk. So we will get to the other peptides, but let's talk about the GLP-1 still. So, I mean, there are risks, and I think most people should, number one, have someone look after it, not order it somewhere. So, I mean, a medical professional look after that script, because the problem is these drugs are made a certain way. So they are, you need to put those letters together, but those letters need to be put together with a strip of resin, and these things, well, once it's put together, need to be stripped off. So you're just left with the letters. And that is, in my mind, what a good pharmaceutical company takes care of, that they just give you the letters. But if you don't follow through with all the steps, the last step is actually stripping everything off. And if someone cuts corners, you will inject something in you that can have quite bad acute effects. And then if these things accumulate in your body, you can have quite a few nasties come up chronically. So, and that's why the things we use, we only use the real tirzepatide, and we prescribe that. So for that very specific reason, you got to trust where your peptide is coming from.
That's fortunately the beauty of big pharma. I mean, there's protocols and quality controls and everything in place to make sure you get a good product. Okay, and with semaglutide and tirzepatide, or Ozempic and Mounjaro is the ones that we have in South Africa available. It's big companies making these drugs, and we know we can use it. We can prescribe that to our patients, and we feel safe doing that.
And that's the one you get at the registered pharmacy.
Yes.
Like your Dis-Chem Clicks, or for the international listeners, it's like a Boots. So you actually give in a script and you get something.
But even giving that script, my concern is always people are prescribing to all their patients, but what's the follow-up? Because we've got very strict protocols in the follow-up. We want to see how much weight they lose. We don't necessarily follow that prescribed escalation of dosage. We take sometimes much longer before we change the dosage, depending on the result regarding weight and body composition. And you need to track that, because we know with the Ozempic or semaglutide, you can get up to 30% of the weight loss might be lean weight that you're losing if you don't do resistance training. So we really hammer on that, getting the lifestyle factors in, getting the resistance training in, monitor that weight loss, monitor how much is lean muscle loss or lean weight loss. And if we start to cross lines, we do two things. First of all, we reduce the dosage, and we increase the resistance training to get them back on track. Also, if we see they lose too much weight too quickly, we don't want to have the body to get a stress response. We also reduce the dose, even though it might stipulate that you need to increase the dose every so and so weeks. We actually manage it according to what we see with the patients. And a matter of fact, often I've got a couple of patients and I don't increase the dose at all, and they're doing fine, and they losing weight according to to what the studies say without increasing the dose. But then we also have other patients where we need to increase the dose.
Yeah, and it's quite interesting. Again, the human body, you cannot predict. So if you're not being followed up, and you buying this from your hairdresser or wherever you get it, that is black market stuff, and you just don't know the purity. So from my perspective, you just need to know where that drug is coming from. And if you have any queries or follow-ups, or you need to know where you can go to get a full report of what is in that medication. So even if it's done in a compound pharmacy, we've just seen that Sapra has been quite angry with one of our compound pharmacies in South Africa because of that, because it needs to be done sterile. You're injecting something under your skin, and I mean, I don't know where the culture is coming from that people are injecting things that they do not know, but it is happening so much at the moment. So people have to be careful.
Listen, I've never, with no other drug on the market, like the GLP-1s and some of the other peptides, it's like, how can you get that from your hairdresser? To me, it's absolutely mind-blowing that people are willing to inject themselves with medicine. They don't know what's in that syringe. They don't know where it's coming from. And they take it must be the real thing.
Yeah, and I think that's why we took so long before we wanted to understand peptides, because for us, unless it was tirzepatide or semaglutide, we did not have a real and traceable means to find the other peptides. And I mean, we've now talked a bit about the GLP-1s and the tirzepatide, but maybe we should shift a little bit and just discuss other peptides that are available in South Africa that could be compounded, because they're not registered as medication. They're compounded, and they are research drugs.
So I think, first of all, what's a research drug? Okay. I think it's clearly stated, like, it's for the purposes of research, but there's different ways people can or are allowed to compound these medications. The problem we have is, and it puts us as medical doctors in a very difficult position, is, on the one hand, you have all these people getting peptides. Let's use the most common ones, is the recovery peptides, like the BPC 157 and TB500. They get it from wherever, in the gym, from the hairdresser, from an online store. They're using these things. Okay. We don't know what they're injecting into their bodies, but they're using it. They come to us because we treat other parts of the body and other conditions, and they ask us questions regarding these peptides. Now, in South Africa, you can compound these things now at a compounding pharmacy, and we've got a couple proper compounding pharmacies in South Africa that we do trust. And legally, or not legally, well, we can guarantee that it's a clean product, at least now, if we use certain compounding pharmacies. But the compounding pharmacy will only provide that peptide on a script. Okay. So we as medical doctors want to help this patient say, no, don't use it. They want to use it on their own risk. But I don't want them to use the one that they got from wherever. We'll rather give them something that comes from a good compounding pharmacy. So that's a bit of a gray area.
Yeah.
Which makes it very difficult. But at least we can get cleaner products because they've been using it anyway.
Yeah, cleaner, traceable products, and I want to come back to that. Yeah, it's quite interesting. I mean, quite a lot of the things happening now in longevity medicine actually made its way through bodybuilding. I mean, even if you think about how we understand testosterone and testosterone therapy, had to make that big turn in the late 80s, beginning of 90s, the Schwarzenegger era and all that, for us to know how much is too much, and how we know now what is too little and what is actually the right dose for testosterone replacement therapy. So, and that's very much like this with the peptides. So the first inkling we had is bodybuilders coming to us and said, but what about this? Because it works. So, and that is quite interesting, is most of the vials I saw first up, and that's 3-4 years ago, was written in Russian, and we had to figure out that that is actually BPC 157, other one TB500 or thymosin, and yeah, so it's quite interesting where this is leading. But again, the peptide is, for me, as a medicine, like, let's say testosterone is like shooting with a shotgun. So you're going to hit a target, but you can't aim at something. But a peptide is like you aiming at something very, very specific. So it's like almost like a sniper rifle, and we need to know where that is going. And I think what we're seeing with the recovery peptides is, or the Wolverine stack as they call it, or the BPC 157, TB500, is that there is something to it. It does help people recover and reduce inflammation.
Yeah, so we've got these buckets. So the weight loss buckets is GLP-1s, semaglutides, tirzepatides and stuff. And the other bucket that we talk about is now the recovery peptides, which is the two you've mentioned, and GHKCU might also fit into that bucket in a certain way. If you go look at the studies on BPC 157, more than 200 plus studies on animal models, mostly rodent studies. It shows improvement. On rodents, it definitely helps with tendon and ligament repair. Okay. There's one problem with those studies, is that most of the studies come from one lab in Croatia, But that said, there seems to be a signal. The human studies are almost none. There's now, in 2026, one study that I started enrolling for hamstring strain study, and we will be very excited about the outcome of that study. But people have extrapolated the information from the rodent studies to humans in mechanism and results. And often, rodents and mice is not humans. So often it doesn't work that way. The problem now is that the signal in the biohacking community is so strong on recovery. Now, we know there's bias. We know people that will respond to something will most likely post more about it than someone, if you've used it and didn't do much, you're probably not going to post, it didn't work for me. The guys that post are the guys that it worked for. But it still seems like there might be a signal in recovery, and we see it as well. There's another thing that might be biased in this situation is that the people that use it is usually top performers. Their sleep are dialed in, their diet is dialed in, their recovery protocols are in place, and now they add peptides. So without the peptides, they might have recovered quicker than a normal person anyway. But they've added the peptides and they've followed all the protocols to get better, and they do get better much quicker. But we don't have the studies. So in BPC 157, there's one small study where they've treated interstitial cystitis type of condition, a bladder condition, but that was not injectable. They actually just infuse it into the bladder. And small study, I think it was something like 12 patients, 10 recovered completely, 2 had an 80% recovery. So there's a signal. So very interested in the new study that they're enrolling for. That would be the first human study where we're actually going to see if there's something to it and see if all the information we're getting or the social signal that we're getting, if it's true or not.
Yeah. And I think the other group of people that we see using it is they've tried all the other avenues. They've tried the cortisone, and they've tried all the other things to inject for, like, let's say shoulders or knees or something, and then they use this. So they as we talk about the pyramid again, so most people are sorted with their protein intake and all that type of thing because it's not cheap getting these peptides. So you have to have had quite a few things sorted before you end up buying a drug that costs in rands 2,000 rand plus. It is, and like you say, that creates quite a big bias.
With the TB500, similar picture. TB500 is actually a small fraction, 7 amino acids from the 43, which is the mother one, is the thymosin beta 4 molecule. That one has got quite a bit of research behind it. The TB500, not much. Came from veterinary background, where they used it in racehorses for quicker recovery. Subsequently, it was banned in racehorses because it's shown to be like anabolic almost. So it worked in the horses, and then it trickled down into the biohacking community in recovery, more soft tissue recovery.
Yeah, which is quite interesting. It's not really approved in humans, but it's definitely banned in human sport. So you got to think that there's something there with the recovery if it's banned by the big sport organizations. So it's definitely banned that you cannot be found to be using that. So
most recovery protocols, they combine the BPC 157 and the thymosin beta. Well, first of all, the TB500 fraction, it's, you don't know if you buy it online, you don't know, do you get the thymosin beta 4, do you get the TB500, which is a shorter one? You don't actually know what you're getting. But the bigger one, the thymosin beta 4, has also got some other pathways. Like, I mean, they've actually investigated a little fraction for post-myocardial infarction infusion studies to see if they can and get some improvement there. So that cardiac benefit is not necessarily in the TB500 fraction as well. And people tend to feel better if they use the whole molecule, the thymosin beta 4, than just the TB500. But in the literature and in the social media, you don't know which one they're actually talking about.
Tell me, in that certificate, the US certificate, how do they split that? How do they call it? What's
Oh,
the
they speak about thymosin beta 4,
Okay.
and they recommend using the thymosin, the whole one rather than just the TB500.
Yeah.
So that's the thinking about it. Dosing is slightly different. So the thymosin beta 4, they tend to use a lower dose more frequently, like daily, whereas the TB500 slightly higher dose twice a week or something like in that line. I must say, in the certification, the one thing that in my head is the whole course, it's presented like this is how it works, this is the clinical results, which, I hear them, but we don't have the studies.
Yeah.
Okay. But the course for me was more to educate myself to answer questions that patients have regarding it. But in some of the longevity clinics, they use these peptides on a daily basis, and they've got large patient numbers using it. I just wish we had more documented data on it in those clinics so that you can have actually real life results presented.
Okay. Maybe then let's shift a little bit to copper, or the blue one.
The blue one. Turn yourself in a Smurf.
Yeah. If you look at the ampule of GHK Cu, it looks blue because of the copper. So I mean, most of the people use that. So we talked about the Wolverine stack, which is the PPC 157 plus the thymosin beta 4 or TB500. So that's one. And then if you add the GHKCU, then it becomes what people now call the glow stack.
Yes.
And that is more towards skin, collagen.
So it also helps with recovery because of the collagen elements it has to it. So also, I think it was discovered in 1973. A lot of data on topical use. And it's been in the market for like 50 years already in skincare products. If you go look in skincare products, you'll probably find some that's got it in. Safety profile, very good. Very few reactions to it. But this is all topical treatments. People are injecting it now. Okay. So the data we have is not on injectables. We know the mechanism. We know how it works through the studies that's been done. But now we've got about 10 years of usage where people inject themselves. But yet again, biohacking community, injury, sports people doing these types of things. And they give positive results on, feedback on what's happening when they use it, quicker recovery when there was an injury or firmer skin type of scenario when they use it for appearances. But difficult, one of those where you extrapolate the data from topical to injectable, and you can't really do that.
Yeah, and it's quite interesting. It's normally mixed in 3, but it's difficult because the acidity is quite difficult in the 3. I mean, the people report that the copper actually burns quite a bit. It irritates the nerves. So again,
so also in the certification, they clearly said that there's compatibility studies on BPC and TB500 together, but not with copper, GHKCU, the copper one.
Yeah.
So they recommend do not mix it because we don't have this stability studies supporting mixing them together. Yet you do get them together.
Yeah, so what we're trying to say is if you see the pens that got PPC 157, TB500 plus the GHKCU, just wonder how that has been mixed and how stable it is. And if you can maybe hold it up against the light, look for precipitation because that is your issue. You're even going to have more side effects if you have a salt within in injectable that should not be there.
So, because all 3 of them function at a different pH.
Yeah,
so
exactly.
To get that point where the pHs of each other overlap is very difficult if you put the copper one in the mix.
Yeah.
It's possible, but then your lab needs to know what they're doing.
Yeah, and it's also the dosage is quite different. So I mean because the amount can get to be quite a lot if you because I mean at the doses that we see is, I mean, the BPC 157, the daily dose is like 0.125 of a mil, so it's like little, but the TB 500 is 0.8 twice weekly, and then the GHKCU is like 0.5 that you do 5 on, 2 off. So
yeah, but it also depends on what the indication is. So if there's an acute injury, then the dosage is slightly different from someone that just needs a collagen production of skin or hair improvement in hair and things like that. So there's dosage differences, and there's not a one size fit all type of scenario, and that's part of the problem. So you can't just buy anything. You need to actually consult with someone that knows something about it to know exactly what you need to take and how much you need to take and for how long. That said, no human trials. Okay, this is on longevity clinics and biohacking data that we're working on, but the data is available. So next best thing, I suppose, to studies is something like that.
It's quite interesting having to be a regulator now. I mean, you have to regulate these things. It's being used everywhere, but you have to try and curb that people don't use the stuff. I mean,
it's a very, very difficult situation because we want to help people, and first of all, do no harm. So, like now you see people using it, and then you say, no, you're not supposed to do that. Please don't do that. But they're still going to do it. Okay, so you in that ethical position where you want to help them to use it at least in the most safe way possible. So it's a very grey area.
Yeah. And I mean, it is so rife, though, that people pitch up with the pens and say, what do you think about this? So now we don't think we now know, but you have to really give some advice and say, there's no name on there. It's just literally that's...
Where did you get that?
And there's no dosage. There's no contact details. There's no one you can call. I mean, you really need to wonder if your pen just says this has got BPC 157, TB 500 plus GHKCU, but that is the sticker on there. Then you're like, So.
If you don't know the lab, you don't know what's in the vial.
Or if you type the lab into your search box and you cannot have a contact detail to call someone there to say, but this is my batch number, when was it made, then it's probably not the thing you should inject yourself with. Coming
if
back
there's
to
a batch number on the info, it's like,
coming back
ridiculous.
to your insulin. I mean, if you see a diabetic handle their insulin, it's like gold for them. I mean, they handle it in a little box, and they always have a fridge. And I mean, that's how you should think about peptides. Is it should be handled like insulin, because it can be as dangerous as insulin if used incorrectly. So
on that point, also, I mean, a lot of the time you speak to someone that got the peptides from the gym, and you ask them, so how much do you take? And say, no, I take about 1 ml. It's like 1 ml of what? What's the strength? How much? No, it's about 1 ml, or 10 mils. I'm not sure. Like dosage is also a massive problem if people get it from some other weird place.
Yeah. And I think the other side of the coin is no one is giving you the dosages. So it's difficult to actually, I mean, even for us when we were researching, when people were like asking us before this course was available, no one actually says this is the dose, because it is actually not the dose. It is how someone out there has worked it out, but it is not like you go and you have paracetamol and your dose is 10 milligrams per kilogram per dose 4 times a day. I mean, that is the dose. But with this is how people normally do it, but there's no set dose. I mean, some of the clinics give 10 times the dose and they ramp it up. It's quite interesting. It's a bit of a cowboy country at the moment. So.
And unfortunately, I can't see Big Pharma getting on board. Something like tracking back to BPC 157. It's a Big Pharma like clean molecules. I like something like a GLP-1. I like GLP-1 fits into that receptor causing that. We can study it. We can do trials. We don't have noise around it. BPC-157 does so many things. So it interacts with so many receptors. So it's very difficult to pinpoint exactly in the controlled study. So I think for Big Pharma to get on board and actually do proper studies on these things, I don't think it's going to happen. Will people still use it? I think they absolutely will use it. I think they're going to use it even more and going forward. It's rife at the moment. So very, very weird situation that we're in.
Mm. And the other side of the coin is a company like Lilly that's made tirzepatide and now making retatrutide is the most valuable company ever, pharma company, more than $1 trillion. So, I mean, they've done that part right, but I don't think they're going to take this on. Just an interesting fact while you were talking about BPC-157. So the BPC means body protecting compound. So it was actually found in gastric juice. Hence, people can take it orally
Yes.
because you can take BPC-157 because it does not get destroyed by the gastric juices because it lives there. That's where it was found. So interesting fact. Now, maybe let's shift a little bit. So we've talked about the recovering peptides. So maybe we should just move a little bit to something that works in the mitochondria. So MOTC. So okay, let's just bring our listeners in again. So mitochondria is where your energy gets made in your cells. So, and it looks like MOTC peptide can stimulate or enhance the energy production, especially for endurance in athletes or in anyone.
To put it in plain terms, it mimics exercise.
Yeah.
Very excited about MOTC, and they say they've actually enrolled the first human trial now, where they're looking into insulin sensitivity specifically with the MOTC trial. That's now 2026 trial that they're enrolling for. So that's going to be an interesting space to watch. The animal data, very good animal data. And it's replicated by other labs, so the data is there. And very interesting, this is the only peptide that's made in the mitochondria. It's a signaling molecule made in the mitochondria. So,
yeah.
And that's the only one that we know of at the moment, as far as I know.
Yeah. So, and what we're talking about is that Krebs cycle. So, I mean, we always come back to the Krebs cycle. So, but if you think about, we talk about the substrates of carbohydrates and how they get split up in pyruvate, and you use them through that cycle. But NADH, that little pathway is where this actually seems to be acting. So it's quite an interesting peptide.
So the MOTC ramps up that AMPK signal. So the same thing that you get with exercise and fasting. So that's that same pathway that you get. So you get that increase in insulin sensitivity, glucose uptake, all the changes that you see with endurance exercise as well, which makes this such an interesting molecule. It also, in the animal studies, it's also showed that, if you combined exercise, now this is rodent models or mouse models, I can't remember, if they combined on the treadmill, they've also got like a little treadmill test that they can do in the animals. But if you use a MOTC, it increases their insulin sensitivity energy systems. But if you add in the treadmill exercise, and you get even better responses. So it also pairs well with exercising as such. So we know with exercise you can get similar activation because you can measure it, and we've got studies showing that your levels with exercise, but it's short-lived. So with this, obviously, again, engineered peptide, and it will be raised for longer. So you get a stronger signal, the exercise signal, with the MOTC.
Yeah, and we should maybe pull it back to our tirzepatide discussion earlier, because that's also where we see a lot of increased insulin sensitivity. So, I mean, I think tirzepatide it's God's gift to us in a injectable. It is absolutely amazing how I see people change with that, and not just weight loss, like feeling good about themselves. And I think it's probably the weight loss and the hormones being active again, and maybe this will move that way, but we don't know yet. So
Listen, and the other thing that I do see, and with tirzepatide, more so than with semaglutide, is that in South Africa, we've got a very like drinking culture, if I can put it that way. We drink a lot. And I do see that if people, the guys that's on tirzepatide, they just stop drinking. And the benefit from that, so the weight loss is like even more than just on the normal tirzepatide, because they cut down on their drinking habits, so they get less liquid carbs. Their overall metabolic profile gets get better so much quicker because of taking alcohol out of the equation. And that's independent of the other things that tirzepatide does. But to me, that's what's like, wow, it really makes a difference.
yeah, I'm glad we circled back, because we don't want to be negative about peptides, as I say. We want to tell people tirzepatide is the most amazing drug we've seen for years. It is absolutely amazing, and it works on everyone. Like, it is, I've not seen it work. So don't get us wrong if I say it that way, that we just want to, people need to focus about what they do with their health when they inject things into themselves. And I'm really a little bit worried about people injecting peptides that's not stripped of that manufacturing layer. Coming back to Mod C, that's going to be quite an interesting movement, and traceability, and do you test, how can you test for it? Because I mean, if you enhance someone's exercise capacity with 10-12%, I mean,
Athletes.
yeah,
Mm-hmm.
athletes might misuse this quite a bit. So, it's interesting.
Yeah, I think, and then, even with the success with tirzepatide and the others, is you also, it's we love it because it works, and we see people change in front of us. But there's always that rebound concern that, are we going to stay on this forever? What are we going to do? Cut down, lower dosage, oral tablet? What is the long-term plan with these patients? So at the moment, we push hard on lifestyle and things, but still, large percentages of people will gain some when you stop it. So
Yeah,
so we don't have that long-term plan. It's not plotted out completely at the moment.
No, you're right. And even the people that get to goal weight, I tell them they can stop now. They're like, no. I want to be on a little bit of this because it actually somehow makes them feel good.
Yeah.
So it's probably a secondary pathway, but most people love having that control and say, but that is where I want to operate, which is quite interesting. And the other thing they say is, but it was expensive in the beginning, but we now realize is we save pretty much that much on food now that we're not eating. So it's
interesting fact.
And drinking.
Yeah.
Yeah.
And then, I mean, we've mentioned a couple of the peptides that's available, but there's a long list of other peptides. You've got like many other peptides available. Most of them we don't have a lot of experience with, especially if we go into the C-Lanks and the C-Max with the neuropeptides and the PK141s and the others.
But I do think we should probably touch on the growth hormone guys, just so that we complete what we see people use. So the ipramolarin and the CJC. So, I mean, that's one we see people pitch up with the pen and say, I'm using this. Is this good? So maybe we should, almost like with when you have the discussion
so it's just a superficial discussion on that. So both of them works by increasing growth hormone through different pathways. So they're stimulated from two different sides. One reacts with the ghrelin receptor, and the other one is a growth hormone releasing hormone receptor that it interacts with. And the two together gives you a slightly bigger growth hormone release than either one on its own.
Yeah, so I think if they go and read about this now, when they see the GHRH, that's what that means, growth hormone releasing
growth hormone releasing hormone.
Yeah, exactly. So and you see that quite a lot when you read, and then you just got to realize that's what that means. It is actually a piece of stimulating that growth hormone releasing hormone.
But the nice thing with these ones is, like, the earlier molecules that were developed caused a lot of insulin resistance and other side effects with it. These seems to be quite clean products. Now, the CJ, you can add a molecule on a DAC, which increase the lifespan of the molecule, keeps it longer in your system. But then you've got a more sustained growth hormone level than one without the DAC. So we prefer the one without the DAC, because then you still get that pulsar release of the growth hormone. Typically, they inject at nighttime rather than morning time, because to try and mimic the natural release of it. But people use it because it makes them sleep better, makes them body composition gets better. They've got tend to get more lean mass, less fat tissue,
less visceral fat,
specifically. And the one thing is that it does, because the one stimulates that ghrelin receptor, you can increase your appetite. So just be mindful of that your appetite can go up. But the idea is to actually gain muscle. So you want to eat more, but then you just need to eat the right stuff, obviously. And that's why they use it. Now, yet again, long-term growth hormone stimulation, is that a good thing? Probably not. Yeah. So what they do at the moment at the clinics and stuff, they cycle through these. Cycle on, cycle off, cycle on, cycle off. In my opinion, not based on any evidence, but nothing stimulated over a long period of time continuously is good.
Yeah, and it's we don't know yet, but I mean, by all the reading we've done, it seems to be a little bit better than using growth hormone like the bodybuilders used to do it.
No, I feel strongly that it is definitely better.
Yeah. Because it's focused again.
Yes,
the
so you still release your own growth hormone.
Yeah.
And you see less of the insulin resistance and the other side effects of it. So, and you do get that little pulsatile, more natural release of the growth hormone because you actually engage the receptors that stimulate the release of it. Whereas with the external growth hormone, then you just give the external one. And remember, there's always negative feedback loops in these things. Yeah. So if you get the external growth hormone, you're going to shut down on another level.
Yeah, so for our colleagues out there, I mean, that's where you start tinkering with the axis and stuff, and you just it's really deep endocrine stuff there. So, but
so there's a less chance if you use these peptides of that happening, but it's not necessarily to say it's not going to happen.
Yeah.
So careful.
Yeah, and that's why they've made that when they say the cycling is 5 days on, 2 days off.
And then you use it for a certain period of time, and then you cycle some time off it again as well.
Yeah. The reading that you've done, the BPC 157, again, normally about a 3-week on.
So that's also, what I see is in the acute phase recovery, I see positive results in acute phase recovery.
Yeah.
Long-term usage, cycle on, cycle off, people use it. I know of a lot of people that's been doing that for years already. They swear by it. I don't know. I haven't seen it in practice as such, because we don't use it as such. We guide people that's using it, if I can put it that way. But I don't really see those that cycle on, cycle off that much in clinical practice.
Yeah.
The acute phase injuries, I do think there's a signal.
Good. Yeah, like you say, we didn't touch on the C-Langs and all those C-Maxes. I mean, that's so in the colloquial words out or mouths out there, that's called the Russian peptides. So they were made from the Russian side. So, and again, the one is a focusing peptide, so it actually, if you read, you use the one to focus and the other one to help you sleep. So
Anti-anxiety.
yeah.
Anti-anxiety focus are the overall type of thing.
Yeah.
They work better with nasal formulations, so you don't need to inject them. You can get them in a nasal spray type of thing. I find it quite fascinating, peptides. I haven't used it, seen someone using it. It's just what I've read
Yeah.
and what we've heard of on the on the course that I've done. But yeah, it's interesting. I think it's one of those things is watch this space. Some of them is going to backfire and some of them is going to be like winners like tirzepatide and the others. We at this point in time just don't know which ones is going to do what.
Yeah. It's quite interesting. We we asked our listeners if there was any major questions, and I think we really only got one, and it was like, tell us about brain function and all that. So I think maybe it was the in this Russian peptides that they were aiming. So we don't really play in that space. I mean, like you say, we try and help our guys that did their own research, and they really want to move in that space, but they're not sure what they're getting. But it was quite a good educational move, because the nice thing about this is you have to know your physiology again. And with the InnerSight way, we had to really dig into the whole physiology of how do you become a hypertensive? How do you become someone that's hypercholesterolemic? And I mean, even today, I had a discussion with one of our first clients that I said, but your son is now leaving school and you've actually got this gene, so you need to start treating your son. So now we're moving the next generation already, which is quite good. So I think just bringing this back to the peptide discussion, I think you're right. I think the jury is still out. We need human trials, and I hope the people that are prescribing it are actually taking some measurements that we can use later for research purposes, which it was actually, or what it is, only really meant to be prescribed for.
I think also one of the things on the course that we did is they stipulated that certain blood markers for certain peptides that you use to monitor it, and then you need to repeat your blood markers. So I think that part is lacking. What I see around, people get it on the internet or wherever, but they don't monitor their blood markers accordingly. So there's certain things that you need to watch if you take these peptides. For instance, if you do take the growth hormone releasing peptides, you would like to know beforehand what's your insulin sensitivity and things like that, and follow it up and see if there's a change, and keep an eye on your lipid panel and so on and so forth. So it's not as straightforward as just taking something. You need to be monitored. And as you said, I just wish there were like a central database where everyone that's using it could put data in, verified data, just so that we had something to work on. It's a very interesting space. I'm fascinated about some of these peptides, but the human data is lacking. So we're doing the using the peptides. It's like before we actually done the data. So that the randomized trial is out there in the world and not where it's supposed to be.
Yeah, and I think if we didn't have semaglutide and tirzepatide doing that well, it might not have sparked the rest of them as much.
I think so, yeah.
But
I agree.
Tirzepatide has put a flame under this, like we can't believe. And I mean, there's a few other drugs in the pipeline that's not peptides, but I think for the peptide discussion, I hope we've put under the umbrella what a peptide is. Yeah. People understand how you must think about which part of the peptide you're using. Are you using it for recovery? Are you using it for energy or exercise energy? Or Are you using it for collagen production or hair growth? What are you thinking when you're using this? And then, yeah, main thing is just make sure you're getting traceable stuff, because I mean,
Absolutely. I think for the medical proof peptides, do it with a provider that knows what they're doing, that monitors you. Wonderful if you can do that. All the other peptides, know your risk, okay? And risk involves, exactly as you said, where is it coming from? Why am I using it? Do I even need to use a peptide? Just ask those questions.
Yeah. Okay, Sean, I hope we've scratched that surface for our listeners.
Shall we
like
take our
always,
heads out of the beehive now?
Yeah. Man, then there'll be lots of bees flying around. But yeah, we're always on the other side of social media, so find us on InnerSight, and we can maybe try and answer some questions if it's possible. If we're not gonna, we can't give medical advice, and I mean, none of this is we actually forming patient relationships. So we literally just want to bring some information out there for people that's using this stuff.
Absolutely.
Thank you.
Thank you, Rudy. Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.